Great. With this, I would like to invite our chairpersons for the session 1, Understanding Newer Nomenclature in Imaging, Dr. Preetam Samant, Dr. Giridhar, and Dr. Ajit Babu Majji. And the moderators for the next session are Dr. Chabblani and Dr. Parveen Sen. The first presenter is Dr. Vasumathy Vedantham, who's presenting on complete incomplete RPE and outer retinal atrophy. Thank you.
Dr. Giridhar.
So a very good morning to everyone. We have started well in time, and I hope we are able to keep the time, of course, with a lot of help from my speakers and the discussants as well. Jay is a little delayed because he's held up in Marriott, so he'll join us in 10-15 minutes, but we'll start the show. So first, I welcome Dr. Vasumathy Vedantham for her first case of the day.
It's cases actually. Thank you, Parveen, and thank you, RISHI and VRSI for having me over here. So I would be presenting few cases about the new terminologies in macular atrophy, CRORA, IRORA, CORA, and IRORA. Macular atrophy and geographic atrophy as part of the dry age-related macular degeneration is one of the most important causes of visual loss. But all that understanding till date has been based on color fundus photography and fundus autofluorescence to a large extent. But with increasing understanding that the outer retinal atrophy actually could be either photoreceptor-based or retinal pigment epithelium-based or a combination of both, and one could precede the other. And with also current improvements in the imaging technologies, there was a need to have new terminologies. And based on that, we have a recent publication by Vas Sadda, al. In Ophthalmology 2018, which is the culmination of the series of the atrophy meetings which they have had. And based on that, we have these new terminologies. So I will be presenting few cases to throw more light on them. Before that, we have 4 hyperreflective zones as per the new SD OCT and the swept source OCT in the outer retina itself, and the terminologies also have changed. So let me just throw some light on that. This is the external limiting membrane, or the ELM, which is one hyperreflective band, and that is basically represents the junctional complexes between the Muller cells and the inner segment of the photoreceptors. And then we have the ellipsoid zone, which was formerly called the junction between the inner and outer segment of photoreceptors. It basically represents the mitochondria within the ellipsoid zone. And the RPE band itself is divided into 2. We have the outermost RPE Brooks membrane band. The RPE and the Brooks membrane cannot be clinically distinguished. And we have the interdigitation zone, which is the inner part of the RPE band, which was formerly referred to as cone outer segment tips, which is how the apices of the RPE cells envelop the outer segment of the cones. So these are the 4 bands which we need to know, and this is the outer nuclear layer, as you're aware. So we have the first case, and this is CRORA, which is complete RPE and outer retinal atrophy, which has 4 criteria. We have the region of hypertransmission of at least 250 microns, a zone of attenuation or disruption of RPE of at least 250 microns in diameter, with evidence of overlying photoreceptor degeneration, which means there is a loss of the interdigitation zone, the ellipsoid zone, the external limiting membrane, as well as thinning of the outer nuclear layer, with absence of scrolled RPE or other signs of RPE tear. So this is the first case. I would like to acknowledge the support of Dr. Anirudh Aggarwal. This is a patient with a bilateral, what we call as geographic atrophy, a sharply demarcated zone of about more than 175 microns in size in the center, with visibility of the outer vessels. Oh, it's saying time's up. Okay. Okay, I'll just speed up. And this is the first case. You can see that there is a zone of hypertransmission of at least more than 250 microns in size in the center. You can see the hypertransmission. And you have the absence of the retinal pigment epithelium and the photoreceptors here. And this is where the RPE terminates. And this is the termination of the ellipsoid zone. And this is the termination of the external limiting membrane. So this is a case of CRORA. And this is the second case which also shows all the findings. If you have all these which are less than 250 microns in isolation, we call it incomplete RPE and outer retinal atrophy, as in this case, as well as here. And this is complete outer retinal atrophy, in which the RPE is present, but the outer retinal layers alone are absent. and disrupted. And this is the second case. This is reticular pseudodrusen here, and the RP lay band is actually present throughout, whereas the external, the ellipsoid zone and the external limiting membrane and the outer nuclear layer alone are disrupted.
Your screen is blocked actually. It is,
Yeah,
time is up.
that's it.
In the interest of time, I think we need to conclude. Sada will take over. Anyhow, he has time.
Yeah.
He will discuss on it.
Okay, thanks.
Okay, now I'm scared. I don't want to exceed the time. But thank you, Vasumathy, for that. One thing I'll just add is some of those examples of IRORA, you have to be a little bit careful because sometimes retinal vessels can cause shadowing and it can look like interruptions. But presenting this on behalf of the CAM group, many of the, like David and Bailey and others who are part of this effort are here in the audience. I thought Vasumathy did a nice job of defining this new entity. It's really defined on OCT, this complete RP and outer retinal atrophy. GA is now just a subset, basically, of this broader entity to be used specifically in patients who don't have CNV. But again, as she highlighted, the three critical criteria, and I just want to call that to your attention, is that you see this type of hypertransmission into the choroid has to be at least of a certain size so that we can identify it reliably. There needs to be evidence of disruption of the RP band. Here you can see the step off, I think, quite beautifully. And then there has to be evidence of thinning of the overlying retina. That's how you identify CRORA. And then as Vasumathy pointed out, when you don't have those features, maybe you have some partial evidence of those features. See how the hypertransmission here is not contiguous. The RP band, you can still see it, but it's kind of ratty, doesn't look good, but there is some evidence of photoreceptor alteration. That is a sign of incomplete RORA. And now when we see that in dry AMD patients, we say that that is nascent GA. This is sort of the histopathologic correlation, which nicely, I think, illustrates those key findings. Here again, you see partial preservation of some of the RP cells, whereas here there is essentially complete absence or loss. I think that helps you kind of to see that the differences between the complete and incomplete phenotype. But as we know in medicine, there are lots of variations, and so these are all examples of cases that would meet those criteria for CRORA, but you can see they can look quite different. So really key in on the actual features that you need to find. Even in this case, you might say, wow, there's a big elevation there, but sure, but there's an interruption of the RPE band, there's hypertransmission, there is thinning of the overlying retina. So you can see that all of the criteria are met in such an example. And here similarly are examples of incomplete RORA, where again, you can see the same features, maybe partial preservation of the RPE band, hypertransmission, not as clear cut, but still some thinning over the overlying retina. Okay, so again, it's easier to understand with longitudinal progression cases. This is a case from Robin Geimer, where you can see the evolution. Here there is no evidence of atrophy, but you can see over time as this case progresses that some features start to develop, and you might even wonder here, is that questionable incomplete RORA? Here you can see some hypertransmission. So I think that's getting pretty close. Here I think it's much more clear cut, where you see thinning of the overlying retina. The RP band certainly doesn't look good, but it's still present, and there is clearly some areas of hypertransmission. And then, of course, here is a complete aurora. So again, they're always going to be in uncertain cases. That's always going to be a challenge, where even these features are difficult to identify, and that's where we think multimodal imaging, highlighted that in the paper, is very helpful in trying to get clarity on some of these cases which are otherwise difficult to be certain. So that's kind of a quick summary, and we're glad to have this for discussion. Any questions?
We'll have some quick questions from the audience. Anybody's they are still thinking, probably we can have a little discussion on how would you like to measure CRORA and IRORA on OCT?
Yeah, that's a great measurement. So one problem is identification. And the reason we think this identification is very important, by the way, if you're wondering, well, why did we even bother with this exercise, is, we really are trying to find treatments for preventing atrophy. We think that's the real long-term challenge. And it's been a challenge so far from a pharma company perspective, because they need these types of earlier endpoints, more granular way of tracking progression. So the hope is that this will lead to that path. And so just being able to identify it at all could be useful, because we can simply say we're trying to see if the treatment can prevent these endpoints from being reached. Using this to actually measure is a bit more challenging. I think you can do that with CRORA. What we do with these measurements, Glenn Jaffe, who's in the audience, can speak to this as well. We key in on that hypertransmission. We can see it on the en-face images. I guess I had it in my very first, you can see it here as well. The en-face image, you can see the hypertransmission. You can use that to start the grading process, but then you oftentimes have to correlate it with the B scans to confirm that the other criteria are actually met. So that's how we do the measurements. With IRORA, none of us have actually tried. Maybe Glenn has tried to measure it. I've never tried to measure it because I think it's probably impossible. But Bailey looks like he has an answer on how to measure IRORA. But we don't try. So far, we've only tried to measure CRORA.
How did you come to 250 microns? What was the reason why you chose 250 microns?
Yeah, that's a really good question, and Glenn might speak to that as well. Really, that was a topic, as Glenn and David and Bailey are all part of this group, can speak to. That was a topic of great debate and almost non-consensus. Many people wanted to have a smaller criteria, 120 microns, because they said large drusen often collapse, leaving atrophy. Why not use that? And we were just worried from a reading center's perspective of doing this reliably. Glenn, do you have something to add?
Yeah, when you look at the images, usually you'll see when people present images, they present really nice looking images that have good resolution and you see the boundaries well, but in a clinical trial you don't always see that. And when you're trying to measure something that isn't a perfect image and you need good reproducibility from one reader or grader to the next, 250 was felt to be one where people could reproducibly measure it in a clinical trial. You can look at an image and you can say, yes, it's definitely atrophy, it's smaller than 250, but to be able to reproducibly measure it, which is what you need to do in a trial, it's difficult, especially when you get clinical images that are not perfect.
And this 250 micron should be a continuous area, or if you have two small patches, and the total is 250.
Oh, to meet the criteria that is a lesion that can be measured, you have to have a continuity, right, for that. But you can have multiple small patches. But the 250 is a contiguous region in order to even meet the criteria that it's CRORA. I think Judy Kim had a question.
Yes.
Yeah, so that was actually, let me see if I go back to my presentation. That was the last slide on the features. Most of these are hidden because we didn't have time, but oops. I'm sorry, say again?
Just the last bit.
Yeah, here, sorry. And we might be... So the autofluorescence features for atrophy are that you see a sharply demarcated lesion. It's black, can be dark gray. Sometimes you have this material that can be in the bed of atrophy, which we'll talk about later on as being it's an interesting material. But basically, and you have to exclude that could be a factor. So that's why when you're using blue light autofluorescence, you oftentimes have to use the companion IR image. Because in blue light autofluorescence, you'll get a central darkening due to the absorption from the luteal pigment. So once you've excluded that, those are the features that we use on autofluorescence, and they seem to correspond quite nicely to CRORA on OCT.
So if there aren't any more questions, we'll go to the next case. Thank you, Dr. Sadda.
Great, thank you. And I would just ask if the discussant can make sure they're up a little bit early before the presenter is done, and just confirm and be prepared with your USB key just in case to load your talk in case you don't find it on that session.
So I invite Dr. Manisha and Dr. Glenn for the next case.
And all the presenters, please stick to the time because it's always better to be on time. Multiple presentations are there.
So I'll do the next one.
So good morning, everyone. And at the outset, I thank Dr. Vishali for this opportunity. So I present a case of a 54-year-old male patient with a history of hypertension for last 5 years. The vision in the right eye was 6/6N6, and the fundus was pretty normal, except for a few AV changes suggestive of hypertension. When we look at the left eye, there was a history of diminution of vision for last 6 months, and the vision recorded was 6/18N12. There was no ocular treatment history in the past. And if you see this color fundus carefully, you have a sclerosed vessel, attenuated vein, which is in the supratemporal quadrant. You have an element of neovascularization over here. You do see some sclerosed vessels on the temporal side. You have a blot hemorrhage over here, and a streak of a subhyaloid hemorrhage. So when we go ahead and we do an OCT-B scan, what we see is that on the nasal side of the fovea, all the layers of the retina are very well distinguished, and you can actually identify them separately. But when we see it on the temporal side, there's a complete loss of the architecture of all the internal retinal layers, while the external layers are quite well demarcated. When we do a fundus fluorescein angiography, we see there's an extensive capillary non-perfusion area. There's also an element of collateral formation over here, and you also have a leakage which is suggestive of the neovascularization. And when we carefully look, there is an encroachment of this capillary non-perfusion area which is encroaching over the foveal avascular zone. When we do an OCTA, again, there's a flow void area on the temporal side, which is merging with the foveal avascular zone over here. And this is corresponding well with the capillary non-perfusion area that we see extensively on the FFA. And when we correlate this to what we are seeing on the OCTB, again, it corresponds very well. You see a complete loss of the architecture, which is corresponding well with the extensive capillary non-perfusion area that we see on the temporal side. While on the nasal side of the foveal area, the architecture of the retinal layers is very well demarcated. And this is exactly what we term it as DRIL. So this is a patient. He presented with an old history of a supratemporal branch retinal vein occlusion. And we tried giving one injection of ranibizumab in this eye. However, when we saw there was hardly any change in the visual recovery of this patient, and he continued maintaining a vision of 6, 18, and 12. So when we went back and saw this patient again, we realized that there's hardly any chance of an improvement in vision. And the patient, we just decided to observe this patient, not expecting any further visual improvement. This patient has been under our regular follow-up, and for 6 months now continues to maintain a 6, 18, and 12. There's a mild resolution of the edema that you see, but there is still the disorganization of the retinal layers which tend to persist. Thank you.
Thanks, Manisha. Excellent timing. With that, I welcome Dr. Glenn.
And
for the
I
discussion.
welcome Dr. Jay Chabblani. Jay Chabblani, please come on to the dais. You are on.
If there are any, somebody who has some questions in mind, maybe they can come to the mic. Before, once the discussion is over, then we'll start taking the questions.
Well, Dr. Aggarwal gave a very nice presentation to illustrate the OCT features consistent with DRIL, which, as she mentioned, was a disorganization of the inner retinal layers. There's continuity loss between the ganglion cell complex and the internuclear layer or the internuclear layer and the outer plexiform layer. This was originally described by Jenny Sun for diabetic macular edema. And why is it important? I think Dr. Aggarwal brought that out, and it's because DRIL correlates with visual acuity. Radwan showed a series of cases where in patients who had DRIL at baseline and then they resolved either early or late, their visual acuity improved at 8 months, whereas when they did not resolve, either it was inconsistent or persistent, visual acuity worsened. As you just saw, this is not limited to diabetic macular edema, though. You can see it in cases of retinal vein occlusion, and we've reported DRIL in association with uveitic CME. These were data from the Visual 1 study, which was a collaboration between Duke and AbbVie, and it included a correlation of visual acuity with cystoid macular edema and DRIL. And you see, again, these findings of the intact layers on your left. In the center panel, you see the discontinuity corresponding to a region of DRIL, and then on the right, you see this was reestablished at the fovea. At baseline, in this case, the two upper panels show the DRIL, and then at follow-up, you can see this, the outer layers are intact, but the DRIL itself has improved. This is a case where you see persistent DRIL in some respects similar to what you just saw, where the outer layers are intact. In the fovea, if you look at the inset, there's DRIL in the center, and I think that accounts for the visual acuity at 2064, even though the outer layers are intact. And we found that if there's foveal DRIL, worse visual acuity at baseline and follow-up, and the extent, horizontal and vertical, correlated with worse visual acuity. The cyst size correlated with worse visual acuity. And this was a better correlate to visual acuity than ellipsoid zone loss and external limiting membrane. And one explanation has been that in the presence of cystic changes, you can get disruption of the bipolar cells, which may not be reversible. But you also just saw that it may be associated with capillary non-perfusion. And from this article from Rick Spade, you see both in the inner vascular layers and the outer plexus flow voids on OCTA corresponding to capillary non-perfusion. So the bottom line is that I think this is a very important biomarker that correlates with visual acuity, not only in diabetic macular edema, but as you've seen in vein occlusion and also in uveitic macular edema, and probably others as well. Thank you.
Any questions from the audience?
Glenn, can you enumerate the extent of DRIL and the visual acuity recovery?
Yeah, so there have been different, both with Jenny's son and then what we've looked at in our report, the visual acuity goes down for every 300 microns increase in the width of the drill. And so you can actually do a function to derive the extent of visual acuity loss correlated with the extent of the drill. When it's present at baseline and then it recovers, that's when you see the improvement in visual acuity. But if it persists, then that's a good sign that the patient's not going to regain visual acuity.
Glenn, when you have inner layers involved, if you're going to apply this to different diseases, I mean, you could have inner layer loss from glaucoma, ganglion cell layer, nerve fiber layer. You could have ischemia, which might be all the layers, or edema, which might be the deeper layers. So how do you sort of distinguish and how do you differentiate between just attenuation of certain layers affected by certain specific diseases versus really truly disorganized layers?
Yeah, it's a good question because different features will give you drill caused by different pathophysiologies, and that's what you're alluding to. So edema, as you've seen, just swelling of the layers can give you what you would call disorganization as based on the definition, whereas in other cases you may have true loss of tissue that has caused the disorganization. I don't think we really know yet in all cases what's accounting for those boundary blurring. For example, in uveitis, we saw more in association with the cystic changes than in diabetic macular edema, and there's, I'm sure, much more of an inflammatory component to the drill that may be causing some of this disruption of the layers, in addition to possibly cystic changes and maybe less of an ischemic component, whereas in diabetic or in vein occlusion associated drill, there may be more of an ischemic component that accounts for those changes in the layers. So I think we actually need to learn more about the pathophysiology to be able to answer your question a little bit better.
Maybe looking at the initial presentation, can you predict this component is going to recover or not?
I think it's very difficult to predict with any degree of certainty who's going to recover and who's not. One thing that I've seen, though, when you have large cysts to start with and it's associated with drill, and then you treat either with anti-VEGF if it's diabetic macular edema or it's uveitic macular edema and you've treated with a steroid and you see the collapse of the layers and then you end up with a thinner retina than normal. Those are the ones who typically don't tend to recover.
Okay, thank you.
Okay, we'll just ask the next speaker to come as well. Abhishek, please can you come for your next
Sorry, is there influence of treatment on drill? So does anti-VEGF have a direct influence on drill without macular edema? So if you have no fluid, is there any worth in continuing with anti-VEGF? Is there some sort of angiogenic response to drill with anti-VEGF?
I think that really gets at the pathogenesis of the disease. So as you saw in Dr. Aggarwal's case, that was a case where it was probably ischemic-based, not VEGF-driven, and so giving anti-VEGF therapy didn't make any difference at all. On the other hand, when you have cystic changes, it's VEGF-driven, and then you treat with anti-VEGF therapy, potentially limiting that stretching and rupture of the vessels, then I think it may make a difference.
I think we need to move on. I mean, it's already far behind.
May I also, okay, Jay is right here with me for the discussion, so please go ahead.
Yeah, good morning, everybody. I'm going to talk about a little bit about ectopic inner foveal layers. I'm just going to show you the different examples of EIFL and the new staging of ERM that has been proposed recently. So what does EIFL mean? It stands for ectopic inner foveal layers. This is the appearance of banded tissue which resembles the alternating hyper and hyperreflective retinal layers over the foveal region in cases that have epiretinal membranes. So the paper that came out in March 2017 was the first one to describe this finding. And I'm just going to show you the examples of this. So these are 3 examples of epiretinal membrane. The upper 2 show stage 1 ERM, What does stage 1 mean? Stage 1 means that the foveal dip is preserved, the foveal contour is preserved, there is an epiretinal membrane. Usually these cases have very good vision. These cases had 20/20. Fovea is clearly identifiable and there are no abnormal retinal layers. The lower one is stage 2. Now the stage 2 ERM also has, the foveal dip is absent, the foveal contour is lost, but you can still identify where the fovea is. These cases also have a fairly decent vision. Now this is a case of stage 3 ERM. This was a male who had a vision of about 660 or 20/20, and the ocular exam showed epiretinal membrane. So stage 3 refers to the banded appearance of alternating hyper and hyperreflective layers, which resembles retinal layers over the fovea. But here you can still identify retinal layers. So you have a EIFL present, but you can still identify the retinal layers. That is stage 3. And if you go to stage 4, now this patient has an even worse vision. It's about 20/180. So what does stage 4 means? You have an epiretinal membrane, you have ectopic inner foveal layers, and the retinal layers are so disorganized that you cannot really make out the different layers of the retina. So these are, this is an example where you can barely make out the layers of the retina, you cannot identify them that well. So this is basically the finding, the EIFL finding, and now we'll move on to discussion. So a little bit, we made the slides, so I just run through the slides. The second in that same folder.
May I also request Dr. Saurabh? Is he here to be ready for his next case as well? Dr. Saurabh. Okay, if he's not there.
Is there? Yeah, come forward. Yeah, the next speaker probably you can sit in the front.
Yeah, row. He has to finish the discussion part. After that, you are ready for the question.
So the points to ponder when we are talking about EIFL is this is an acronym, or this is a name given to the finding where you are seeing a de novo emergence of organized retinal layers, ectopic layers. Now my problem with that is that I find it a little difficult to locate the fovea exactly in cases where you have a lot of distortion, especially in stage 4 ERM, where you have a lot of distortion. It's sometimes very difficult to locate the fovea. And on top of that, when you have a thick ERM, it basically causes shadowing of the underlying structures, making it all the more difficult to find it. Now, when you're taking a macular scan, if you've not been very particular and you yourself don't do it, the lines of the scan, the B scans, may go above and below the fovea because the fovea is displaced in a case that has a thick ERM. So sometimes you may miss it and you may be going just a little above or a little below. Let me just show you. The second point I would like to discuss is a disappearance of EIFL in some cases. The papers that have discussed this finding and shown the results after surgery, some of the papers, some of the cases had a disappearance of an ectopic inner foveal layer after surgery. So there is a tissue that is being formed and then disappears when you've not really done anything much to the retina except peel the proliferation that is on top of the retina. And this is, the disappearance of EIFL is only seen in cases where you have a good restoration of the foveal contour. If you don't have a good restoration of the foveal contour, those are the cases where they've shown that the EIFL persists. So let us look at this case. This was a stage 4 case that I have shown. But if you go a little bit above and below, what you see is that there is a centripetal movement of the retinal layers and there is a infolding. Yeah, I just have a couple of slides. This is another video where if you look carefully, I've slowed it down. This is just a movie. And at this point, you can just barely make out that this is the point where there is a fovea. If you had just taken the normal, raster lines, you may have missed the fovea and must have thought that there is, fovea is unidentifiable in this case, and you have misdiagnosed it. So the proposed mechanism is that in stage 1 and stage 2 of ERM, where the maximum force is outwards, that is the centrifugal force, you have the central bouquet abnormalities because of vertical traction on the foveal photoreceptors. And when you have a lot of when there is a thick ERM and the force is predominantly centripetal, there is an infolding, and this basically on the OCT appears as banded layers in the region of the fovea. The scans of stage 4 are usually not that clear because of the shadowing from the underlying ERM, and this is probably what leads to the appearance of EIFL. Thank you.
So just a quick comment only from Jay Chabblani.
Only one comment from Jay.
Only one, because he can go
exhausted
on
both the
otherwise.
times.
So I think one of me, I'm just going to make one comment, and which itself is very controversial, is to actually compare and differentiate these grade 4 ERMs from combined hematoma, which we discussed in Trivandrum meeting as well, because many a times it is challenging to differentiate combined hematoma from grade 4 ERM. I think multimodal imaging, especially autofluorescence, sometimes makes a difference, but still histopathology does not confirm.
Yeah, let us
David.
open for the discussion now.
So a couple of issues with when Andrea Gavetos, first of all, should get credit for putting this classification together when he was a fellow with us at Jules Stein. But one issue was to be absolutely certain you were looking through the exact point of the fovea when there was a progression from an earlier grade to a later grade with ectopic interfoveal layers. So we went back in this particular study, we only used track scans. So these scans are going through the exact same point of the fovea, and we have sequential analysis on a number of them where you can actually see progression from a grade 1 or 2 to a grade 3 at exactly the same point where it was a lower grade of ERM. So I'm not sure it's exactly true that we weren't able to identify the exact fovea. We were, and that was a very important issue, is to make sure that we're looking at the exact track scan to make sure that there's no, this wasn't a scan that was a little bit above or a little bit below. And so there was a great degree of precision and accuracy in this regard. What was really surprising, too, is if you magnify these scans, you actually see a continuous internuclear layer and interplexiform layer going across the fovea. And the obvious response would be to say this is just traction, bringing the layers together from either side. But with very high magnification, there seems to be a very continuous interplexiform and internuclear layer. And so this was causing a great degree of question about how this would happen. Could there be some kind of proliferative mechanism here, maybe a Mueller cell mechanism that's activated and plugging that area between those two layers and making it look continuous? We didn't think this was just apposition of the layers because we were unable to see a break point. There was actually continuity. And I think the importance of this grading scheme is that it correlates with vision. But the limitation is that there are so many other issues with ERM in addition to these changes. You have cystic changes, schitic changes, you have foveal bouquet changes that we published. And so there are many different contexts of ERM and how they can affect the grading and surgical prognosis.
Dr. Shroff, since you are there, I just want you to make one quick comment, if possible, on how to look at progression of ERM and decide which step should you operate, because only 20% will progress. Just one quick comment. And I also invite...
I think that really requires another study. I think that it's still... this is a question that's always asked of me is what then now is the exact stage to operate. Certainly the stage 3 and the stage 4 especially have a poor prognosis. So I think the simple answer is you don't want these ERMs to get to stage 4 when the retina is disorganized, and probably the more ideal time to operate is stage 3, but there are still other considerations, the patient's subjective, objective visual acuity and other issues that should go into that assessment.
Thank you. Dr. Saurabh, with your case. Thank you, Abhishek.
Morning. I thank Dr. Vishali and VRSI for this opportunity. I am presenting a case of acute macular neuroretinopathy. So this is what we saw in the patient. There were these white areas of retinitis with hemorrhages all along the blood vessels with hypoautofluorescence seen on the autofluorescence and inner retinal hyperreflectivity with cystoid edema and neurosensory detachment. So this was a 37-year-old lady with exanthematous fever. According to the patient, this was her third episode of chickenpox. For the past 7 days, she had fever, and she presented in a very toxic state with headache, vertigo, neck stiffness, and joint pains with scabs over the scalp and forehead, bilateral sudden loss of vision with finger counting 0.5 meters and 1 meter vision. Was diagnosed elsewhere as bilateral ARN. She was on IV acyclovir 600 milligrams TDS. So extensive investigations were done. Out of that, mostly they were normal except for IgG, which were raised for serum rubella, CMV, and HSV. A workup for rheumatic diseases was also negative. VDRL HIV was negative. Serum toxo was non-reactive. Serum ANA negative. Serum double-stranded DNA negative. P-ANCA, C-ANCA were negative. Antiphospholipid antibodies were negative. CT scan of the head and MRI brain were normal. And VEP was normal. Serum protein electrophoresis was within normal limits. So in the angiogram, we saw areas of blocked fluorescence corresponding to the areas of retinitis. And there was some leakage along the blood vessels, if you can see here. As I told before, the OCT showed inner retinal hyperreflectivity. This is a swept source image of the OCT showing inner retinal hyperreflectivity. And you can see these cells in the vitreous overlying the areas of retinitis. And also there was cystoid macular edema with neurosensory detachment. So a vitreous biopsy was done for this patient. Vitreous aspirate PCR for CMV, HSV 1 and 2, VZV was negative. RT-PCR for chikungunya was negative. Patient was already on IV acyclovir, tablet Val acyclovir. TDS was given for the next 10 months and along with steroids tapering doses. And also Avastin was injected for the cystoid macular edema in the right eye. Following that, tab Val acyclovir was continued BD for the next 6 months and then 1 gram OD for another 6 months. So this is how the clinical picture evolved. You can see that these white areas were gradually gone, and there was inner retinal atrophy, as you can see on the OCT. The vision improved in the left eye to 624 parts from finger counting 1 meter. However, the right eye remained with very poor vision of finger counting 1 meter. So at final follow-up, this was the vision finger counting 1 meter. Left eye had improved after almost a 3-year follow-up to 612 parts. So this is a case of presumed viral retinitis in an immunocompetent female who presented with clinical picture like ARN involving the posterior pole. The patient was negative for HIV antigens and had no history of immunosuppression. Thorough investigation ruled out possible association with systemic rheumatic disorders. Yeah.
You lead the discussion to Dr. LG, who's here, Dr. Lingam Gopal, he's from Singapore.
In the first place, I had difficulty in labeling it as acute macular retinitis as is described in the literature, because this is probably a viral retinitis occurring in the macular area, but it's not same as what we by connotation mean by acute macular neuroretinitis. Typically, it's classified into type 1 and type 2. Type 1 is otherwise labeled as the paracentral acute middle maculopathy, and this is localized to internal to the outer plexiform layer and hence involves the inner nuclear layer, results in atrophy of the INL, while type 2 is supposed to be probably more called as acute macular neuroretinopathy, which is localized below the outer plexiform layer, involves outer retina, and results in atrophy of the outer nuclear layer. And both are supposed to be a retinal vascular in etiology, not necessarily infective or inflammatory, although many can follow non-specific viral illness, use of ephedrine, contraceptives, etc. I thought I can just share 2 cases which probably are more akin to what is classically described as PAM and acute macular neuroretinitis, because the features are rather subtle. They are not grossly seen as necrotic retina, unlike what you have shown. Now, for example, in this case, you can hardly make out a problem in the left eye macula on fundus photography. And it's with the left eye that he had a complaint of reduced vision, has 6/6 vision. But you see here, the outer nuclear layer is opaque or hyperreflective, right from the fovea all the way here. And you see even the fellow eye, which is non-symptomatic, has a patch of outer nuclear layer which is hyperreflective just below the outer plexiform layer. Similarly, in this case is a little different. He presented with a left eye drop in vision with a picture of something like a Pertussis retinopathy, like picture, more grossly evident patches of whitish patches deep to in the deeper layers of retina. And you see here a combination of hyperreflectivity in the outer nuclear layer below the outer plexiform layer, as well as pillars of hyperreflective shadow in the inner nuclear layer as well. Something like a combination picture of acute macular neuroretinitis with the PAM kind of picture. But in the fellow eye, where the patient is asymptomatic, there is a patch of hyperreflective shadow in the outer nuclear layer. So this perhaps are all subtle features, not so gross as what you have shown. And I'm not sure whether we are dealing with the same entity. So I think we're dealing with probably two different entities, although anatomically what you said is right. It involves the macula, it is acute, it is a retinitis, agreed. But what we mean by acute macular neuroretinopathy or neuroretinitis from the literature is a little different from what you have described. So the disease, your case is more gross, spread over the fundus, mostly full thickness retinal involvement, and poor vision at presentation, and you strongly suspect viral etiology, although your PCRs were negative. And these, of course, I'm not going to discuss, but that as far as PAM and AMN are concerned, ultimately they're presumed to be vascular in origin, involving the capillary plexus, deep capillary plexus, intermediate capillary plexus, and the etiologies tend to overlap between the two. PAM has also been described with diabetic retinopathy and CRVO. I think I'll skip the other slides and let people with more experience share their experience. Yeah.
I think what Lingam pointed out is almost right, that your case is like more frank viral retinitis. Whereas we are in AMN, we are seeing more subtle changes which need to be, and they need to be followed over time. Yeah, please.
Maybe there was a bit of confusion, I think. You were describing your case as ARN, right? More of acute retinal necrosis.
Yes.
I think it was just a misfortunate sort of typo that the M got into where the R was. So I think you presented a case of acute retinal necrosis, but the program says acute macular neuroretinopathy, so that's caused some confusion.
Yes.
I just want to clarify a little bit about this distinction between type 1 and type 2 PAM. David Seraph, who's the senior author on that paper, he'll never let me live this down. That was probably a mistake in terms of how we classified those, that PAM is really an infarction of the inner nuclear layer, as you said, due to an ischemic event that affects the deep vascular complex. And acute macular neuroretinopathy is still, no one really knows for sure whether it's truly ischemia just affecting the deep or inflammatory, and those are really different things. So I think there's PAM, there's acute macular neuroretinopathy, they're separate. They shouldn't be called two versions of PAM. And the last thing I want to say is that you have to be very careful that when you look at OCT, structural OCT scans, when there's tilting, and you may not realize the scan is tilted because you might be scanning it at the wrong axis. But whenever the OCT structural scan is tilted, all of a sudden Henle's fiber layer becomes hyperreflective. So I think the first two cases you showed were actually just this directional change in reflectivity of Henle's fiber layer. And then the case of the CRVO that had the perivenular PAM, that was real PAM. But the other one where you saw that band, that was due to a staphyloma. So if you scanned that eye vertically, you'd see that that scan was tilted, and that's why you had that little band of hyperreflectivity. So you can really get fooled if you don't realize your scan is tilted.
Thank you for making things more clear. As I invite Dr. Shahana for the next case on PAM.
Is this what you mean? This is what you meant?
So on that side, that's really just because you don't appreciate it because the scan looks horizontal, but that might be because of the direction you're scanning. So if you look at the outer nuclear layer on the right side, look how thick it is. And then you look at on the left side and you see that all of a sudden the outer nuclear layer is very, very thin. And that's because the outer nuclear layer, or what we call the outer nuclear layer, is composed of
months with this recurrence. The highlight here is this outer retinal tubulation that we see in the fairly typically described location temporal to the macula, with this pseudocystoid appearance with these defunct photoreceptors lining it. And this we advised intravitreal repeat ranibizumab. Patient accepted it. Post ranibizumab, there was fairly impressive regression. But what's interesting to note are these a fresh crop of outer retinal tubulations which popped up in a fairly atypical location, which is foveal. It usually is temporal. Foveal location is pretty atypical. But what was even more interesting was that in subsequent visits, there was coalescence of this outer retinal tubulations. And as we kept observing this, it went on to progressively enlarge and become what you might like to call a giant outer retinal tubulation. Another interesting case, an outer retinal tubulation in what is not commonly seen, geographic atrophy, and we find this snapshot showing this ORT right here at the edge of the geographic atrophy. Now we know from studies that have looked at the post hoc analysis of the CAT study that about 15% of patients who present without outer retinal tubulations post 1 year actually go on to develop outer retinal tubulations. At the same time, patients that had outer retinal tubulations at the 1 year time point, if I remember right, 1 out of 7, again working out to 15%, those disappeared. So that leaves us with a few points to ponder. Do ORTs always signify chronicity and potential non-responsiveness to anti-VEGF treatment? Is this an inflection point in the course of the pathology? Is it a biomarker in many ways for more aggressive treatment or less aggressive treatment? Should we step back? Does coalescence of ORTs have any significance at all? Do they represent persistent activity in a healing CNVM? Can early stage ORTs, if it early, be reversed with aggressive anti-VEGF treatment, or should we pull back? And ORTs in geographic atrophy, their specific pathophysiology and clinical relevance. Thank you.
Thank you, Anand.
Yes. Sure. Disappointed.
Few questions from the audience. Please come to the mic on the floor. We can start immediately.
So I thought that was a great summary from Anand, actually, and I'm going to, if I can get my slides quickly, please. Can you turn this one on? Oh.
Last time I talked wasn't there, so okay.
It's okay, a few more steps we have counted for you for the day.
No worries. Okay, so let me talk briefly about outer retinal tubulation. I'll try to answer some of Anand's questions, but then I'll have Bailey and Glenn fill in what I don't answer. But basically, this is a finding, as Anand pointed out, it's a finding really at the outer nuclear layer on OCT. And the key finding is, can you switch?
Yeah.
There we go. Okay, good. Perfect. Thank you. So, because my other talk was projected. Okay.
Yeah, go ahead.
Now I have nothing. Okay, great, perfect. So the key finding is obviously you see that hyperreflective ring with the central hyperreflective lumen, because oftentimes we're distinguishing these from cystoid degeneration. So they can be circular, ovoid on the B scan depending on the angle of intersection. And so that, I think, really highlights to you the fact that they're actually interconnecting tubes. They're not little rosettes or something of that sort. And that's where Bailey, who first described it, he's the father of ORT, so I guess you can call him the FORT. But in any event, he really identified their tubular nature is something that's best appreciated on en-face OCT scan. So that's how we like to find them now. And so in any event, he again described these same features. Some of these ones that are more established, you can actually see the little remnants of the outer segments or photoreceptor material present within these ORT lesions. One of the things, Anand shows beautiful cases in GA and in CNV, and of course we see these commonly in this setting, but I just want to point out that it can be in any retinal degenerative disease. Bailey's published a nice paper on mitochondrial disorders where you can see that. You can see this in Biedes, and these are all Bailey's images in these various conditions. And we've seen it in choroideremia. Actually, we've published on that not so long ago. In any event, the commonality in all these cases is attenuation or loss of the RP. So a hypothesis is you lose the RP or loss of RP function. That can lead to a loss of polarity of the photoreceptors. And sometimes when we're teaching fellows and residents, we say the photoreceptors are huddling together for dear life because they've lost their RPE support. Now, they tend to begin at the area where there's a free edge where you sort of see the edge of the RPE, of an intact RP, and the ORT sort of began at that free edge. We call that process intubulation. As these ORTs start to develop, you can see sometimes at that edge they can actually open up into the subretinal space. So sometimes there's subretinal fluid associated with the ORTs, and there's a component of it that's treatable because it's not actually within the tube. So something to keep in mind. Oops, can't. Uh-oh, my slide is trapped, not advancing. Okay, so Bailey and Christine Curcio have published some nice papers on the evolution of these from a histopathologic standpoint. I'll let Bailey comment more on that. One of the things that's interesting, I actually found this image from their paper most interesting, which is a little free RPE cell trapped within the lumen. I think that supports the concept that maybe, you know, this is kind of a tube that's extending out to where the RPE are. It might be like a lifeline tube or a nutrient transport conduit tube that's leading to an area where there actually are RPE cells. At least that's the way we think about it. Sorry, I'm going to take a few extra seconds if I can here, because I'm just about done. So in any event, we care because you have to avoid confusing these with real fluid, which requires treatment. Here's a patient with persistent ORT despite multiple anti-VEGF therapies. Glenn Jaffe has published very nicely from the CAT study that eyes that had worse vision outcomes seem to have more of these ORTs. I think that's very consistent and expected because, you know, there's going to be loss of RPE to see these ORTs. So there's going to be atrophy in those areas. So I think that makes a lot of sense. And then, of course, we can see them in GA in multiple cohorts now. We see that the rate is about 20 to 25% in these eyes. Again, easy to detect with en-face imaging. And so we care about in GA because we've demonstrated that eyes that actually are able to generate these ORTs, there seems to be a slower growth rate of the atrophy. Again, really easy to appreciate. You can see them all extending out to the edge, right? They're always out to the edge of the GA lesions, which I think tells you something about their pathophysiology, and we've tracked their progression over time. As the atrophy grows, the ORTs kind of recede back to that edge over time, which I think is kind of interesting as well. So in any event, you know, we think that these development areas of RPE loss extend or open into areas of preserved RPE. I believe, again, we can see what the others think, they're a conduit for metabolic exchange for photoreceptors that have lost their adjacent RPE. So again, something to keep in mind. You can see it in diseases other than AMD, and I already said that comment. I already talked about Glenn's finding that they're associated with worse vision, and we think that they may be associated with a slower actual growth rate of the atrophy. That's it, and we have some comments.
If I could just make a quick comment. That was an excellent summary. Nice presentation. I think one of the things we should consider about outer retinal tubulation, and this is we found through histology, doing direct clinical pathologic correlations with Dr. Christine Curcio, is that this is really a Mueller cell-driven process. And you can have outer retinal tubulations that don't have a single cone cell. So it's really what you're seeing around the border, the hyperreflective border, you know, that's the tight junctions, that's the Mueller cells, okay? And you can have just a few photoreceptors. And so in dry AMD, Mueller cells become activated. They try to protect the cones. They form a sheet sort of on Brooks membrane that Jerry Luddy has shown very nicely. They start to stain for GFAP because they're activated. I think that in this epiretinal membrane that's called lamellar hole-associated epiretinal membrane, evidence is accumulating that that's Mueller cells going out onto the surface, probably trying to protect the neurosensory retina. We'll have hopefully histopathologic proof that it's Mueller cells soon because we have a donor. And you also can get that through defects in Brooks membrane. You see Mueller cell come down, and sometimes you see. So we have to start thinking about what role the Mueller cells are playing in these degenerative diseases, because they're doing a lot of things that we don't normally think about. And this will come up again in my type 3 talk.
Yeah, but the question remains.
Mueller cells are really critical in their formation, clearly.
The question remains, what Anand has asked is, should we declare that it is a chronic process and we cannot treat, or is it an indication that we should still go on injecting anti-VEGF?
So it's not an absolute, right? So the fact that they're there does reflect some degree of chronicity because you must have some RPE loss in order for this to happen. But you can have ORT and still have evidence of exudation that requires treatment. The critical thing is you want to make sure that you see, in addition to the ORT, some other evidence of exudation, so true fluid. That's actually the key.
Our recurrent CNVM had an ORT which went. That ORT went and new ones came up. So it looks like it's a dynamic process.
Well, there is, so Bailey's published on the dynamism, but I can say in just tracking the evolution atrophy, as the patch of atrophy enlarges, there is a dieback. So Bailey's sort of published on this life cycle, and so clearly, as you know, the later ORTs, you can have no photoreceptors and just that Mueller cell ring, because the photoreceptors, just because you have maybe something, I believe, trying to keep them alive, doesn't mean they're going to survive. They're going to probably still die. And so there is an evolution. Clearly that can move. That's why before you say that they've actually disappeared, I would want to know that you've looked at them on en-face scans. I really can't emphasize, Bailey made that very important contribution on identifying the importance of en-face OCT to recognize these. At the reading center, we use en-face OCT, much like we do to recognize atrophy, we use that as a great screening tool to find ORTs.
Yeah, just a couple points. One, I think it is true that you can distinguish the ORTs from fluid, the latter being one that you could treat with anti-VEGF. And looking on FOS is very helpful, but also to distinguish the specific ORTs from fluid, it's helpful to look at the cross-sectional B scans. And ORTs will be present on consecutive B scans, and often you'll see a circle, and then all of a sudden it turns a corner, and then you'll see a tube. Whereas the cystic changes don't usually do that, aside from the fact that they don't typically have the hyperreflective border. The other thing is that Vas and I have had discussions about whether having ORTs in the association with geographic atrophy is a good thing or a bad thing for rate of progression. And it may be that, because we've actually published that if you have ORT within the center of the atrophic area, that's a sign of faster progression. And one thing that we probably haven't done as carefully as we need to is look at the relative location in the center or along the periphery as you were describing, because it may be that the location at the peripheral edge of the atrophy goes along with slower progression, but if you have it inside the atrophic area, which may be a sign of more chronicity, that a sign of more rapid progression. It's something that needs more.
Okay, thank you very much, and I think we need to
move on to the next case,
Darius.
which is on shrimp by Dr. Dries, and the discussant for this is going to be Dr. Michael Stewart.
Good morning, everybody. I'd like to thank the organizers for this opportunity. Could I have my slides? So I'm going to talk about SHREM. SHREM is not really rocket science. It's subretinal hyperreflective material, and it's a morphological feature we are seeing on spectral domain OCT as hyperreflective material located external to the retina and internal to the RP. There's a wide range of SHREM in macular disorders, includes neovascular tissue, fibrosis, exudation, vitelliform material, or hemorrhage. Any of these can present as SHREM. So I just show you a few manifestations. This is a 74-year-old gentleman. He was a case of multiple myeloma with light chain disease in remission. He had a CNVM. I just put the different types of outputs we get with our standard OCT. You see the black and white, the multicolor, and inverse black and white. And you can see with the red arrow the area of the SHREM. And we've given 3 anti-VEGF injections, and you can see the massive reduction in the SHREM post-injections. So, but sometimes SHREM doesn't budge. It doesn't budge with anti-VEGF therapy. So this was another gentleman, similar age group. So we saw this material, and post-anti-VEGF, you can see the follow-up. You need to rethink the diagnosis. And lo and behold, autofluorescence gives us the clue. So this is a SHREM associated with a vitelliform dystrophy with the increased autofluorescence signal seen in the lower slide. New kid on the block, OCTA. OCTA helps to distinguish between vascular and avascular SHREM. Vascular SHREM is seen in active CNVM type 1, 2, or 3 as the neovascular tissue. And you can see how beautifully the network has reduced on the OCTA, and the fluid has gone down on the B scan with anti-VEGF therapy in the vascular form of SHREM. So to conclude, it can be a manifestation of varied macular disease processes. In AMD, it has been found to be associated more frequently large scar tissue formation and a poor final visual acuity. Thank you.
Thanks, Dries, for finishing before time. Please, Dr. Moore.
Thank you. May I have my slides, please? So thank you for Dr. Shroff for that very nice summary of really what's a very broad topic of SHREM, or subretinal hyperreflective material. And what's important to start off with is to understand that SHREM is really an OCT diagnosis. It's not a clinical diagnosis. This spans multiple disease processes. And I do want to point out the list that he gave us of what SHREM may represent. Everywhere from neovascularization, hemorrhage, fibrosis, fibrin or exudate or vitelliform material. And he gave us examples of several of those different things. If we focus in on the AMD side of this, we know that SHREM is found in the majority of treatment-naive eyes with neovascular macular degeneration. And in fact, about 2/3 of those are accompanied by subretinal fluid, and 1/3 of those are accompanied by intraretinal fluid. We know that for the neovascular AMD eyes, most of them will respond to therapy, but persistence is common. And if you look at the CAT data at 2 years, about 54% of eyes had some persistent SHREM after 2 years. And then if you look at the other side of that, what does SHREM mean from the standpoint of a biomarker or predictive ability? And we know that if you look at the eyes in cat that didn't do well visually, but 85% of those had SHREM from the beginning. So SHREM we know is a negative biomarker, and we'll probably see that later on in this morning's talk on biomarkers. Many authors think that if you have persistent SHREM despite aggressive anti-VEGF therapy, that may represent fibrosis or scarring at the level of the RPE in the subretinal space. We do know that SHREM is a negative predictor, and we know that from multiple studies, presence of SHREM, thickness, laterality, and location all can serve as biomarkers. We know that you can take eyes that start off with looking fairly good, and then SHREM will accompany the presence of new neovascularization. And here you can see both the false color scale as well as the gray scale. It's important to realize that though SHREM is a broad diagnosis, multimodal imaging is important to try to whittle down and understand what is actually causing the SHREM. And so color photographs here, you can pretty much rule out that this is going to be lipid or hemorrhage as the cause of SHREM in this case. And we know that you can get SHREM from both classic and occult choroidal neovascular lesions. With aggressive therapy, you can often have resolution of SHREM as shown in this case. And I just want to point out in the bottom slide, and Dr. Shroff showed us the multicolor and the multi-modes of looking at these, is that SHREM is that often if you're presented with colors, do go back and look at the grayscale because things like SHREM show up much better on grayscale than they do on colors. So what to do about SHREM? Well, treat it aggressively. Try to use multimodal imaging to define what is the cause of it, but don't give up on therapy, at least at the very beginning. If you have persistence, it may represent fibrosis, and it may be a biomarker for poor therapy. And then in efforts to try to work through and define what is the cause of SHREM, Bailey Freud and his colleagues put out this paper where they called it subretinal hyperreflective exudation, which is a subset of SHREM, and they broke it down to fibrin and exudation, and in their series, they actually had a fairly good response to therapy when they were able to rule out fibrosis, hemorrhage, and exudation, or lipids rather. Thank you.
Thank you, Dr. Michael. Before the audience comes in, one basic question that I had, do we really need this term? Because we have better imaging modalities which are able to see what is there in the SHREM.
So, no, very, very good question, especially now that we recognize the commonality of this. And the answer probably is no, we don't. And if we look at our last slide, and the one from Bailey was subretinal exudation, hyperreflective exudation, I think that's our first step to getting rid of SHREM. Because we need to be more specific as to what the cause of hyperactivity is and not just term hyperreflectivity itself.
I think it is definitely required to diagnose SHREM in the beginning, because like Bailey has described about the exudation, because what we are noticing whenever you treat these patients who presents to you with the CNV and an active exudation, when you treat these patients, the disease responds to the anti-VEGF, but this exudation eventually becomes a thick scar at the fovea, which is not let the vision grow really good. So what we have been doing, I have been doing is that whenever I see exudation at baseline with a lot of exudation along with a CNV activity, I treat these patients with the steroids in the beginning, which actually I feel that this exudation is primarily because of the inflammatory process, and the steroids are going to take care of that. And now we have submitted the paper where we are comparing the cases with or without steroids, and we are seeing that the scarring size of the scar as well as the size of the scar and the visual acuity is in benefit with the steroids.
You give Osidex or Triamcinolone?
Yeah. So I think SHREM is a starting point. It's a starting point for saying we have hyperreflective material, but that shouldn't be your endpoint in the diagnosis. Yes. And now you need to know what's the cause of this, because that's going to determine how aggressive you are with therapy and when you may stop therapy and watch because you've had maximal improvement.
Absolutely.
I think the term SHREM as defined by Darius and as being discussed is an ambiguous one because it does not actually define anything. It takes fibrosis, it takes CNVM, it takes fibrin material, it takes vitelliform material. It's actually no condition. It's like saying you have exudative ARMD. It means nothing. So effectively now, to my mind, SHREM is that situation where you're talking of something active, and what you're describing is a different thing altogether. What you're describing is a fibrin kind of material,
That's what
which
Bailey
is
said,
active. No, so I'm trying to say that the rest is not SHREM. The rest has its own definition. Whittley-form material is Whittley-form material. It has its own characteristics. A CNVM, which is healing, has a different characteristic. The fibrin material is the one which I would consider as truly speaking SHREM, because this is something that has different characteristics. When it heals, it will either fibrose, and now the characteristic will change. What you're describing as SHREM will be a little less well-defined. It will be more amorphous, though hyperreflective. Now when it transforms, when it heals, the fibrin material will become either a fibrosis, in which stage it will now become well-defined.
So I think we need to subclassify.
Yes.
I think we need to subclassify.
And alternatively, it will disappear. The second thing that can happen to it is it will disappear. So either it will disappear or it will fibrose. This is the, so it is not one
we agree, yeah.
I'm glad that we have taken the first step.
Thank you for the very pertinent points. We'll go to Dr. Tapas, I think.
Yeah,
We'll
the term is definitely there, and the OCT finding, it's a OCT finding, and further definition need to be refined.
You need to define based on clinical assessment.
We'll go on to the next talk.
Very good morning, and thanks for the opportunity. Are the slides put up now? So I present before you a little bit on this guy who presented to us with history of RD surgery 4 years ago, who did not gain back his vision and had no light perception in the left eye. So he came for a second opinion whether we can do something for the left eye. While evaluating, he had a vision of 20/20 with minus 5.5 diopter sphere in the right eye, and there was RAPD in the left eye and angles were open in the both eye. What is characteristic picture in the right eye was a semi-opaque round orange-red lesion nasal to the optic disc, almost 180 degree, with a myopic conus, as we can see here, tessellated background and advanced cupping. Left eye, and there was no fundus view because of the total cataract, and he had a B scan done elsewhere, we showed a total detachment. Now this is the corresponding lesion in the red-free photo. Now when we took a line scan across the disc and the lesion, we can see there is a hyporeflective intrachoroidal cavitation just adjacent to the optic disc, and the tissue here, the connective tissue, that is less reflective than compared to that temporally. Compared to that this side, and we can see, so this entity has been given different names so far. Like few years ago, when I used to see such type of picture, used to think that it's a peripapillary detachment and used to do a 360-degree scan to rule out any slit-like break. But in fact, the first report which came, which described this as peripapillary detachment involving the neurosensory retina. Later on in their paper, they found with newer dimensions OCT, they found out that it is actually in the choroid. But most the paper in 2013 showed by Yehe et al., they said they characteristically found that they are more common in those who are myope and old age. But however, it can be seen in the younger age group or older age group also. But when it is seen in the younger age group, usually they are associated with myopia, with myopic conus. And when it is seen in the hyperopes, it is associated with the older age group. Usual characteristic is the inferior to the disc, but they can be seen anywhere. The ICG, OCT angio shows absence of the choroidal vasculature in the few reports, and usually it is stable and visually insignificant. Among the various pathogenesis, that the one which is interesting to me is the tissue of Elsting, because of the degenerative process, separates from the disc and the choroid tract, showing its a cavitary effect, or something akin to the splitting of the retina that happens in those degenerating conditions, either age or glaucomatous eye or high myopia, that splits the choroid, giving this appearance. So one need to distinguish this from mimickers so as to avoid unnecessarily extra investigations and panicky. So in case of high myopia and glaucomatous eyes, we need to look at the peripapillary area. Thank you.
Thank you, Dr. Tapas. over to Dr. Adnan for the discussion of PPCC.
Great, thank you. So thank you for a very nice presentation, Dr. Tapas, and a great summary. Just get my slides up. Oops. So as Dr. Tapas said, this was originally described by actually Bailey is first describing it as a yellowish lesion around the disc. And in the original, I presume, Stratus days of OCT, it was felt to be, oh, sorry, I've got two slides. This is your one, sorry. So this is your original paper from the early 2000s, where I presume on the Stratus you felt it was a RPE detachment.
Yeah, I mean, it's totally wrong, but I didn't know what this is. I mean, I was looking at
But I think the
like
observation was great. This was good observation, and with it was not a criticism. With the best kit you had in the day, it was the interpretation that was not necessarily wrong with the OCT. And I'm going to go about OCT.
The RPE is up.
Let him present first, then we can discuss.
So yeah. So I'll come back to this. We'll have a lot of chat after. I was just giving him the excuse up front. So it's being nice. So subsequently, Alan Godrick's group felt that when they looked at it more carefully with next generation OCTs, it was a cavitation splitting the choroid, not an RPE detachment. Further imaging studies have suggested again in the Stratus days that maybe in a subgroup of patients there is a communication between this entity and the vitreous cavity, but in every other study, and in my experience, when you do detailed raster scans, you don't see that communication. And it's really this isolated paper, and that comes towards the pathogenesis postulated. We mentioned a differential diagnosis. It's not an RPE detachment, where as you can see clearly the elevation here on a modern OCT. Certain OCTs do alter the curvature of the eye, but you're not really going to see an RPE detachment. Obviously, CNV will have different reflective properties than a splitting of the choroid. Polypoidals and other differential can be peripapillary in certain subgroups. That'll be an elevation again of the RPE sometimes with medium hyperreflectivity, or the double layer sign may be seen. Again, very different from this entity. Peripapillary tumors, osteomas can be orangey around the disc, but you'll have changes in the outer retinal atrophy, and obviously the ultrasound and the fluorescein will be very different, and combined harmatome will have the changes in the inner retina and fibrosis on the surface. So easy OCT ways of distinguishing it from the other lesions. Epidemiologically, the best study to date is in Chinese myopic eyes, where over 15 to 20% of eyes had cavitations, and half of these did not have the yellowish lesions, so you wouldn't even be able to pick it out in clinical examination. It's also now being described in emmetropes and hypermetropes. We had a brief discussion of the pathogenesis. There's no evidence of any functional significance, and there's no good evidence of prognosis, but since it's seen more commonly in older groups than younger groups, one assumes there is some progression, but maybe that'll be up for discussion. Thank you.
Thank you. Just a few points, yes.
Can I have a quick comment?
Yes,
Can we go back to the slide you showed a PED? This is the one. So this is not related to this discussion, the discussion of Henle fiber layer artifact. Actually, I worked on a paper in Michigan on chloroquine toxicity. So many times I saw this one, Henle fiber layer thickening, and interpreted it as ONL thinning, but actually anything, not only a tilted scan, but something which causes irregularity in the RPE, like we saw in PED. So the Henle fiber layer shows up on both the sides. So this can sometimes give a wrong, misinterpretation that ONL is actually thin, but actually it is a Henle fiber layer that shows up.
Billy, you wanted to say something? Yeah, that was a great overview, and definitely we got the anatomy wrong on that first paper. But I've always been interested in this, and I guess the most relevant recent observations, which to me support that this is more of a developmental thing that occurs during axial elongation, is if you scan the nerve at various angles, what you'll notice is that in all of these eyes, the choroid is much thicker on the side with the cavitation than on the side 180 degrees away. So it's sort of, it just relates to the angle of the staphyloma and I guess how the nerve is entering the eye. It's just, there's, I guess, some forces that cause the choroid to be much thicker and actually split apart on one side, and then it's very thin on the other side. And not all of them have the cavitation. Sometimes it's just sort of a diffusely thickened choroid. So we tried to throw out this name, parapapillary choroidal thickening and cavitation, didn't stick. So, but that was the point.
I agree. I think, I mean, the associations, in the Beijing eye study, the strongest associations, not with axial length, it was tilted disc and the staphyloma, again, highly suggesting it's primarily developmental, and probably if we had a longitudinal study, and I think the studies in China where we can have long-term OCT scanning over time will answer this question extremely well.
Just check the thickness on one side versus, you'll see a dramatic difference. So it's just, I guess it's just, there's just only a certain amount of tissue that can fill that sort of space, sort of mechanical.
Dr. Bailey, how can you say that this is only physiological, or is it any pathological implication? Because whenever you are coming up with this kind of an observation, it's always important for us to define.
Well, in our first paper, we had up to like 15 years follow-up, and some of those patients I followed, for another 10 years now. So basically, in all of the cases that were in the original series, they never really caused any vision loss. What could happen is if you had parapapillary atrophy, sometimes that would kind of expand through the cavitation and you would sort of, then it would just look more atrophic. But we never had any cases develop secondary CMV or any vision loss that appeared to be
So
related.
the risk is the associated staphyloma and making sure you don't over-investigate the patient. But I think the entity is reasonably well recognized now that hopefully that won't be the case.
Okay, thank you.
All right, we'll move on with the next case.
We'll move
Kanika.
on.
Very good morning. I would like to thank VRSI and Dr. Vishali for this opportunity. I'll be describing a representative case which shows a subset of retinal findings which we saw in our patients of dengue maculopathy, and we've given a descriptive term for the same. Dengue-induced inflammatory ischemic fovealitis and outer maculopathy or deform. I'm moving to the case now. This was a 35-year-old Asian female who came with complaints of painless diffusion vision in both eyes for the past 3 days. The vision was 6/9 in the right eye and counted in the left eye. We can notice some hemorrhages in the fundus in both eyes and these grayish yellowish lesions surrounding the fovea, which are more prominent in the left eye. He was diagnosed with dengue fever, NS1 antigen positive 10 years ago. At the time of ocular symptoms, he was afebrile. Although he had thrombocytopenia, the platelets were 50,000 per microliter at the time of ocular symptoms. The baseline FFA, in the early phase, it is showing some blocked fluorescence corresponding to the hemorrhages. And in the late phase, we can see some subtle perifoveal leakages. And again, they are more prominent in the left eye. This was the swept source OCT, and the top panel is showing the baseline images. The right eye is showing the presence of these vitreous cells, and these can be seen in the left eye as well. We can see the presence of these cystoid spaces in both eyes, and there is presence of this characteristic conical lesion, which is involving the fovea in the left eye. We can see hyperreflectivity of the outer plexiform layer in both the eyes. Now, we put this patient on oral steroids, about 0.75 mg per kg, and these were gradually tapered over the next few weeks, and he showed a gradual improvement in visual acuity, and at 3 months, his vision had improved to 6/6 in the right eye and 6/9 in the left eye, and we can see that there is disappearance of these vitreous cells. The inflammatory signs really show the good response to the steroid therapy, and you can see that there is a disappearance of the cystoid spaces, and the conical elevation has also disappeared. We did OCT angiography for the patient, and you can see that in the superficial as well as in the deep capillary plexus, this is the top panel of the baseline, there was capillary flow deficit, and at 3 months, there was no significant recovery in the capillary plexus flow. So, thereby we concluded that probably the inflammatory signs show resolution, but the ischemic damage is more permanent, and the resolution of ischemic changes was not complete. Thank you.
Thanks, Kanika. Dr. Vishali, just a few points on discussion.
Yeah. Continuing with the discussion, the case she showed, we had 16 patients which we saw last year that were diagnosed based on positive serology, as Kanika showed. The mean age of presentation was around 27 years, and the initial best corrected visual acuity was 0.66, but it did show improvement on follow-up. The mean duration of low vision was 6 days, and all of them had fever before presentation, and mean platelet count, as Kanika showed, was low. So if we look at the anterior segment, that did not show inflammation in any of the patients. In all 32 eyes, we had altered foveal reflex and parafoveal retinal discoloration indicative of fovealitis. 10 eyes showed superficial retinal hemorrhages in the macular area, as was shown by the case presented. Vitreous cells somehow were not too appreciable on slit lamp, but on OCT, swept source OCT, we could appreciate the vitreous cells, and we went back to the slit lamp and we did see. These patients did not have obvious retinitis lesions of necrotizing or non-necrotizing. Retinal periphery was all right, and fluorescein in around 75%, we just labeled it as normal. In another 25, they showed some subtle perifoveal leak, as is shown in the case, and that too in the late phase of the angiogram. The findings on swept source OCT, as I said, they did show posterior vitreous cells, hyperreflective cystoid spaces in the inner nuclear and outer plexiform layer. Fovealitis, that was the conical elevation, was seen in 68% of the eyes, and all showed edema of outer plexiform layer, disruption of ELM, ellipsoid, and interdigitation zone in 75%. On OCT angiography, superficial and deep capillary plexus showed flow deficit area. So during the follow-up, there was recovery of the inflammatory signs in terms of vitreous cells and fovealitis. However, flow deficit areas persisted in both superficial and deep plexus and correlated with visual acuity. So there are two proposed mechanisms of this entity, ischemia and inflammation. Inflammation we were able to take care of with steroids, ischemia not, but whether the introduction of steroids prevents the ischemia or progression of ischemia or not is something needs to be seen on longitudinal follow-up. So this is what it's published already, I think now. Dengue-induced inflammatory ischemia, fovealitis, and ocular maculopathy. Thank you very much.
Thank you, Dr. Vishali, for nicely summing
I have
it.
a question. I mean,
Yes.
can it be seen in chikungunya, and why call it dengue? I mean, can it be seen in other diseases like chikungunya?
Our
Even
patients in our series had dengue. Chikungunya we don't see in our part of the country, so I don't have. Maybe it will come from Bangalore people because they report a lot of chikungunya.
I agree with your findings. In Singapore, we see mainly dengue type of maculopathy. The chikungunya cases that we've seen have had more retinitis rather than just fovealitis.
Yeah.
Do we have any correlation with platelet transfusion or blood transfusion in such cases?
We did look for the blood transfusion. We did not find any correlation. Only patients who developed this did have low, count, but all of them had not received transfusion because sometimes it was 75 or 1 lakhs. So all of them had not received platelet transfusion.
So back in my fellowship days, we have around cases of 10 to 12
We'll,
cases.
I think, sorry to interrupt, but we are a little running late, so we'll go on to the next case. Thank you, Dr. Vishali and Dr. Kanika. I invite Dr. Srinivas Joshi for his case on dome-shaped maculopathy, which will be discussed by Dr. Adrian Ko.
Good morning, everyone. I would like to thank Vishali Madam and the entire VRSI team for this opportunity to be with you all. So I'll be discussing a case of dome-shaped maculopathy, and we can have the discussions at the end. This is the 66-year-old male myopic patient who presented with diminution of vision in the left eye since 8 years. He was treated with a single-dose anti-VEGF injection in the left eye, thinking it to be a CSCR in 2009 elsewhere, but he did not improve. On examination, his right eye, the best corrected visual acuity was 6/18, and the left eye was 6/36 with no improvement. He actually had a radial keratotomy done 20 years ago, and the residual refraction in the right eye was -5 spherical with -4.5 cylinder. And he had a little bit of NS1 with posterior subcapsular cataract, and the fundus showed mainly the myopic fundus features. So this was the right eye, as you can see, a slightly dome-shaped with a slightly thickened sclera. And the angiographic features did not reveal any important findings. Coming to the left eye, you can see a mild dome-shaped macula here, the inward bulge, what they describe in the textbooks, with some amount of the subretinal fluid or the serous retinal detachment. And from the presentation to the 1-month follow-up, we observed this case, but it still persisted. So this is the angiography of the left eye, where we can see there is a mild stipple hyperfluorescence, probably due to the window defect. However, there was no much of leakage points or the CNVM seen in this case. And this is the fundus autofluorescence, showed a hypoautofluorescent area in the center, suggesting that there is an RP atrophy at that area. So a lot of things have been discussed in the literature, whether to observe such cases. People have tried anti-VEGF giving aflibercept also in these cases, but did not have much improvement. People have tried laser, focal laser, as well as MPLT, but with no much benefit. And I have just read a few of the literatures also shown that spironolactone has shown a little bit of improvement in few of the cases, but none of them are actually justified in these disorders. Because as we know the pathophysiology, this was first described by Goucher et al. In 2008, and then Imamura has later on described it to be a subjacent scleral thickness, probably because of which causes the inward collapse of the sclera according to the Laplace law, and because of which there is a choroidal outflow obstruction. And these were what the hypothesis being done in most of the literature. I think I would request Dr. Adrian Coe and other members and the panel to discuss more on this case. Thank you.
Thank you, Dr. Joshi. I think very nice case to illustrate some of the important points with dome-shaped maculopathy. Actually, it is not a new entity. I think if you look back at all your old slides and the OCTs, you probably have seen it, but perhaps you didn't pay attention to it. I think it was first described in 2008 by Gaucher. This is Alan Godrich's group as an inward convexity of the macula, usually within the concavity of the staphyloma. So the initial description was the necessity of a staphyloma with that paradoxical inward convexity. But as you mentioned, it's not really thought to be choroidal. It's thought to be due to a focal thickening of the sclera, and most times the choroidal thickness in other series have been normal. And in fact, it means that foveal scleral thickness can be at least twice the average for age-matched and refractive error-matched patients. But more recently, this is from Artman's group in London, it's also been reported in patients with hyperopia as well as retinal dystrophy. So it's, I think as the observation increases, we will see more and more of these cases. This is just one study from Giovanni Storenghi. You'll see the characteristics of DSM. What's interesting is that 33% had subretinal fluid, as you've shown in your case. Choroidal neovascularization in this series was in 25%, and some patients go on in a small percentage to lamellar macular hole. What's also interesting is the dome may not be circular. The implication of this is that you'll need to know, you'll need to see them in radial scans. If it were horizontally oriented, you might not see it on the horizontal rasters, so you'll need to see it on the vertical rasters, and vice versa. So the important thing is when you see a dome or you suspect a dome, get a radial raster. As I mentioned, complications, up to 67% of patients with subretinal fluid really the key is what do we do with these patients, because we don't understand fully the pathogenesis. We can discuss this later. There was one case of observation reported stable, so not all cases need to be treated. Half-fluence PDT has been suggested, but if the choroid is normal, then what are you trying to achieve? Will you end up with more atrophy? Most patients are refractory to anti-VEGF. In literature, bevacizumab, ranibizumab, aflibercept have been tried, and spironolactone has been reported to be successful in only one case. I have not seen any case series to suggest that there's any specific therapy for subretinal fluid in dome-shaped maculopathy. I'll be very keen to hear the views of the other experts in this room. Thank you.
I just wanted to add one comment that we have to be careful. Many a times these DSM cases does have CNV associated. In those situations, we really need to treat them with anti-VEGF. Adnan?
So just regarding the choroidal thickness, so overall it's not thick because it's a myopic eye, but in our series with ultrasound and EDI on all of them measured sclera and choroidal thickness. So the sclera is thickened locally under the apex of the dome or ridge, but the choroid is also locally thickened relative to more peripherally. So it is actually both. In terms of treatment, we found no real beneficial treatment, but again, it's the whole nugget of when they develop CNV, even if it's extrafoveal, if it communicates with the dome fluid, the vision drops, even if the fluid doesn't increase. So it's obviously this whole thing of why can you get good vision with subretinal fluid unless you have CNV present and it somehow changes the constituents and drops the vision and makes them symptomatic, which is the trigger to treat.
But one of the things which we can convincingly tell the patients that in this disease, even if you have a shallow fluid, patients don't lose a lot of vision. They remain good 20, 30, 20, 25.
Unless you have CNV.
Or atrophy in the long term, which is a subgroup which will develop progressive atrophy, even though it's the thicker choroid in the center over long term.
If you see Srinivas' case, there is a RP elevation with the fluid. This may be indicator for towards some case kind of thing where anti-VEGF probably connect. Otherwise, a plain dome-shaped maculopathy, I would agree with
even
you.
With
that
chronic fluid, we wouldn't treat it.
We did try with, he did have an anti-VEGF injection elsewhere, but it was not successful. He brought the OCT scans with me, showing typically the similar images. In between, he had no fluid. Again, he had a recurrence of the fluid. So this process keeps coming and going with no much promising
The difficulty
treatment.
is when they get CNV, in the UK, we pool our patients that get treated by the fellows. You have the CNV, you inject it, the CNV resolves, the vision improves, but the subretinal fluid persists like CNV and CSR, and they just keep getting injected. And it's quite a difficult treatment decision.
I think OCT angio may help.
Yeah, OCT angiography is quite useful in some of these cases.
Dr. Shobit, last comment?
Yeah, that was just Dr. Tufel answered my question partly. My question was to Adrian and to Jay, that we see these dome-shaped lesions with a myopic CNVM. Typically, we give them 2 injections and some fluid persists. So should we keep on chasing the fluid or just stop when the visual acuity has stabilized?
I think
that was my exact
So the key judgment is whether or not the choroidal neovascularization is active or not.
Yeah, the myopic CNVM, whether we should chase the fluid or just stop after 2 injections.
I would stop and observe if you think it's low.
I think it's time to stop here also this session. It's a very good deliberation by all the speakers as well as discussants. We reassemble at exactly 10 o'clock so that we'll be on time, and registration counter is open. Whoever not registered,